Our next discussion is on retrosternal goiter patient posted for thyroidectomy by Dr. Surekha Patil Madam. And to chair this session, we have Dr. Avinash Bhosle, Dr. Mohan Patil, and Dr. Jyoti Kulkarni. I request chairpersons to introduce our speaker.
It's my pleasure to introduce our speaker, Dr. Surekha Patil Madam. She is MBBS DA DNB, and at present she is professor at D.Y. Patil Medical College, Navi Mumbai. He had national and international publication around 34. Her area of interest is obstetric anesthesia, regional, then pain, holistic growth of PG student. Her major achievement, she was past president, Indian Society of Anesthesiologists, Navi Mumbai branch, ex-governing council member, Maharashtra State Anesthesia Association, life member, Association of Obstetric Anesthesia, Indian Society of Anesthesia, and IMA. She got award from Sri Puraskar Award in 2017, Nari Shakti Award 2024, then Jewel of India, then International Yoga, she is International Yoga Trainer, and Maharashtra State Chapter Award for COVID-19 Pandemic Management by Misakon, Maharashtra. Please, Madam.
Thank you, sir, for elaborative introduction. Esteemed chairperson, faculties, colleagues, and dear students, a very good afternoon and happy Navratri to all of you. So, thyroid case, it's a long case. Everyone, all the PG students get in exam, and you prepare thoroughly. There are definite questions and definite answers. You prepare, then definitely you are going to good in your exam, and you will clear the exam with good mark. But unfortunately, there are very few students in the PG, this assembly now at present in the afternoon session. But whoever are here, they will definitely get the benefit of this lecture. So imagine a patient who presents with persistent cough, shortness of breath, difficulty in swallowing. But surprisingly, the problem is not in the lung and the esophagus. Instead, it is located deep within the chest, behind the sternum, that is a retrosternal goiter. And we as anesthetists, this is a big challenge for us to give anesthesia for this patient. So these are the learning objective for today's talk. First, understand the implication of retrosternal goiter in anesthesia, review the preoperative assessment and the preparation, and discuss intraoperative management and postoperative care. So it always seems impossible until it is done. And retrosternal goiters are defined in many ways, but widely accepted definition is that 50% of the enlarged thyroid gland is below the suprasternal notch. The goiter is graded according to its position in the sternum. As the mediastinum is a confined space, the enlarged gland causes the pressure symptoms necessitating the goiter to be removed. So the term retrosternal goiter was first used in 1749, and in retrospective study, the incidence is 0.2 to 45% according to Raffel et al. And according to Newman and Shah, it is 2 to 40%. There are various types of the retrosternal goiter: subclavicular, retroclavicular, substernal, mediastinal goiters. This is morely common in endemic goiter areas, and mostly diagnosis is at the 5th and 6th decades of our life, and female to male ratio is 4 to 1. So these are the different definition of the retrosternal goiter by different personalities. So we'll go through the classification and grades of the retrosternal goiter. According to Lehe's classification, it is a relationship to aortic arch. Grade 1, it is extending nearly to the arch of aorta, where grade 2 is if it is beyond the arch of aorta. Higgins gives the classification according to percentage of the mass in the neck or the chest. It is more than 50% in the neck, then it is a substernal. more than 50% in the chest, it is a partially intrathoracic, and if it is a more than 80% in the chest, then it is a completely intrathoracic. However, Cohen and Co. has also given the grades depending upon the intrathoracic component of the thyroid, grade 1 0.0 to 25%, grade 2 26 to 55%, grade 3 51 to 75%, and grade 4 above 75%. Hunes et al. Has given the new classification of retrosternal goiter and approach, surgical approach. If it is above aortic arch, then surgeon takes the approach, cervical approach. If it is aortic arch to pericardium, then manubriectomy, and it is a below right atrium, they take the full sternotomy. This is very important. Whenever there is a patient comes with retrosternal goiter, there are these other compression syndromes which we come across, and we have to keep in mind to see all these signs and symptoms. Cough, which is a compression related, asphyxia, tracheomalacia, laryngopharyngeal reflex, hypoxia related to right side of the congestive cardiac failure, tracheal varices. Vascular components are superior vena cava syndrome, venous thrombosis, esophageal dysphagia and varices, cerebral vascular transient ischemia. Neurologically, we have to keep in mind recurrent nerve palsy, phrenic nerve palsy, Horner syndrome and chylothorax. Clinical presentation we get mostly in the 5th or 6th decade. 30 to 40% patients are asymptomatic. In only 20% patients, there is no palpable mass you will get. 10 to 20% patients may have prior history of surgery. There will be acute airway obstructions, cough, dyspnea. Dyspnea will be positional dyspnea, nocturnal breathing difficulty in 35 to 60% patient. Dysphagia, hoarseness of voice and venous obstructions will be there. What are the investigations we have to do when this type of patient we come across? Thyroid function test is a must. X-ray chest and neck epilateral, this is very, very important investigation. Ultrasonography, CT scan, MRI, indirect laryngoscopy, again this is very important investigation in any thyroid case which gives the condition of the vocal cord functioning. Then flow volume loop to assess the airway obstruction, particularly in retrosternal goiter patients. Virtual bronchoscopy we have to do in if it is a huge retrosternal goiter, huge thyroid, because it gives the 3D image of the airway, narrowing of the airway and intraluminal extension of the tumor. Also we have to do the ECG, 2D echo and all other blood investigations. So this is X-ray chest and neck pictorial which gives the information of the first evidence of the mediastinal mass, and this correlates the image of the substernal goiter. Also it gives how much percent of your swelling is inside the sternum, 60% to 90% cases. So this investigation is very important. CT of neck and chest X-ray. Also it gives the whether trachea is narrowed or where it is deviated to right side or the left side. Again CT scan gives the most important information for evaluation and planning for the surgical approach of this patient. Also it gives whether it extends beyond the sternum, how much it is extended and any vascular area is involved. MRI shows the relationship with the great vessels in advance so that during intraoperatively surgeon and anesthetist can take care of the bleeding and intraoperative blood loss. And it is superior to detect the esophageal and tracheal invasion MRI investigations. So how to manage this patient? By thyroid suppression, giving the levothyroxine to reduce the volume of the goiter, radioiodine therapy and the surgery. So this is actually this lecture for the postgraduate students. So this slide is for the postgraduate students who can remember the signs and symptoms of the hypothyroidism and hypothyroidism. And this is the case scenario. We will discuss the practical points of the specifically retrosternal goiter. Suppose 43-year-old female patient presents with the complaints of midline swelling extended to both sides of the neck with multinodular goiter, has dyspnea and dysphagia, and she is posted for the total thyroidectomy. What other information we have to know in the history? Duration of the swelling and development of the symptoms. If longer the duration, there increase the chances of tracheomalacia and the malignancy. We can differentiate the primary and secondary hyperthyroidism. Second, difficulty to breathing while sleeping the patient, because stridor in particular position which will not allow the patient to lie down during the position or at the time of the induction of anesthesia. Then we have to keep in mind drug therapy and anesthetic implication. Patient might be on beta blockers, carbimazole, propyl thiouracil, duration of the drug therapy, improvement in the symptoms after the drug therapy, and in anesthetic implications of all these things. And any muscle weaknesses, because hypothyroid patients, especially Graves' disease patients, can have the myasthenia. So in this patient, this is the history of present illness. Midline neck swelling extending to both sides of the neck. Swelling gradually increased in last 8 years. Swelling was painless and progressive in nature. As the size of the swelling increased, the patient started having discomfort in breathing on lying down. She needed 2 pillows or lateral position to sleep. She also noticed hoarseness of voice 1 year back. History of breathlessness in lying down is a positive sign. History of difficulty in swallowing solids and liquids and snoring. These are the positive signs in this patient, positive historical. Then no current, this is a negative history also we have to rule out. No current history of fever, URTI, no constipation, no diarrhea, no any visual disturbances, no history of irregular menstruation, hair loss, no any, this MET score is more than 4, patient can climb more than 2 flights of stairs, no history of any other swelling and no history of pain in bones. So we have to take the past history, no history of diabetes mellitus, hypertension, any coronary artery disease, CVA or seizures, no history of hospital admission, any previous surgeries, no history of radiation exposure. Obstetric history is very important in this patient because she is the mother of 1 daughter, 16 years old, normal vaginal deliveries, no history of any thyroid disorders during the pregnancy, no menorrhagia, no amenorrhea, etc. Family history, mother had thyroid disease but not got operated. Personal history of this patient, appetite normal, patient is non-vegetarian, bowel bladder symptoms are normal, sleep is disturbed because of the difficulty in the positioning when she sleeps, non-alcoholic, non-smoker, menstrual cycle is regular, 5 days of the cycle. Medication history, patient is on carbimazole, 10 milligram once a day and propranolol 40 milligram OD for 2 years. On general examination, patient is conscious, well oriented to time and place and person, height 155 centimeter, weight 90 kg, BMI 38, receding mandible is present, no exophthalmos, no eye signs positive, skin normal, no pallor icterus, clubbing cyanosis or edema, JBP is not elevated, carotid pulsation felt and undisplaced, this is a very important finding, no tongue or hand tremors, febrile, no muscle wasting signs are there. Vitals, pulse is 76 per minute, regular in rhythm, normal volume character, no radio-radial and radiofemoral delay, no apex pulse deficit, all peripheral pulses are felt. Blood pressure 130 by 80 millimeter of mercury recorded in the right arm in sitting position. Respiratory rate 16 per minute, abdominothoracic, no accessory muscles used. SpO2 is 100% in room air and temperature in axilla is 98 Fahrenheit. Now we'll go for the local examination of the thyroid. Inspection, this is a piezoelectric method. In the exam, examiners might ask you how you do the inspection of this thyroid swelling. So I'm not going to go in detail because I think most of the students are knowing. This inspection we have to do in the sitting position with head thrust backwards against the hand clasped behind the occiput. Large swelling with an uneven surface noted in the anterior neck extending between the bilateral sternocleidomastoid, lower border reaching up to sternal notch and upper border is asymmetrical. Right side of the swelling appears bulkier and larger. Swelling moves with the deglutition, does not move with the tongue protrusion. Skin over the mass is stretched, no ulceration, sinus, scars, edema or no dilated veins on the swelling. On palpation, this is 13 by 6 into 3. Patient's neck is slightly flexed and standing in front of the patient when you do the palpation. Large firm mass of the breast 6 centimeter extending below the sternocleidomastoid palpated in the anterior neck. Upper border is short 6 centimeter from the mentum, 1 centimeter from the right angle of the mandible and 5-6 centimeter from the left angle of the mandible. Variable surfaces moves easily with the deglutition, but here you cannot go below the swelling because of the retrosternal extension. Trachea is not palpable because of the huge swelling. Carotid artery is palpable, no thrill, no bruit. Cervical lymph nodes are difficult to palpate. Coccus test is positive, which is very important when we are doing the thyroid case. And Pemberton sign is negative. On this, neck examination reveals the large goiter, difficulty in palpating the trachea due to mass effect, signs of the airway obstruction, that is a stridor. Percussion note over the sternum is dull, which is again positive point for the retrosternal goiter, and auscultation, no bruit in the mask. Then what are the different methods of examination of this thyroid? There are Lehes methods are there and Creel's junior methods also there. Then why you are not going underneath the swelling? It is very important to know to rule out the retrosternal extension. This is the test, Pemberton test. How to do it? This is very important. Patient is asked to raise his upper limbs above his head with the arms touching to the ears. And if there is a substernal extension due to the venous obstruction at the thoracic inlet, the patient will have congestion of the face and patient goes to the distress. Then what are the importance of Coccus test and Berry's sign? Coccus test is a slight pressure on the lateral lobes of the thyroid which produces the stridor. That's why we have to do before the surgery. And this will be positive when thyroid swelling has compressed the trachea from the both sides. Importance is we have to keep in mind, keep ready small size of the endotracheal tube. Endotracheal tube should be placed beyond the narrowing of this thing. Then the Berry's sign, malignant thyroid engulfs the carotid sheath completely so that the pulsation of the artery can be detected, and this is the Berry's sign. A benign swelling of the thyroid gland merely displaces the carotid sheath backwards where the pulsation of the carotid artery can be felt. So what are the different eye signs in Graves' orbitopathy? So these are the various signs: von Grape signs, Stelweck signs, Joffrey signs, Del Murphy signs and Mobis signs. I think most of the PG students are aware of all these signs. Then airway examination, bilaterally nasal passage is patent, interincisor gap is 2.8 centimeter, which is reduced. Sternomental and thyromental distance could not be measured due to swelling. Upper lip bite test 2, TMJ no ankylosis, tongue size is a normal, dentition all present intact, no buck teeth, no loose teeth. Neck circumference is unable to measure due to huge swelling. Cervical spine is normal. On airway examination, receding mandible, decreased mouth opening, protruding teeth, MPC grade 4. Neck flexion and extension is restricted due to the swelling. Indirect laryngoscopy, overhanging epiglottis. Why patients with the goiters are considered to have a difficult airway? Any huge thyroid swelling can produce an anterior-posterior compression and hence can produce the difficult mask ventilation. Once the patient becomes the unconscious and the complete weight of the gland following on the trachea which produces the obstruction. So before giving the muscle relaxant, we have to always keep in mind how much swelling is there. Whether after giving the relaxant, swelling is going to sit on trachea and then you will in the mess of the respiratory obstruction. So difficulty in introducing the laryngoscope as the tumor may come in the way. Any lateral deviation of the trachea will distort the anatomy of the larynx and produce the difficult visualization. Lateral deviation of the trachea and larynx will produce improper positioning of our LMA, and this will make a difficulty in ventilating the patient using supraglottic device and also produces the difficulty in intubating the patients using the intubating LMA. Presence of the swelling over the front of the neck will also produce impossible access for surgical airway and retrograde wire intubation when patient goes in the cannot intubate, cannot ventilate situation. Then what is the importance of sleeping pulse rate? In the exam, examiner will definitely going to ask where you have seen the sleeping rate or not and how is it recorded. She should be well sedated to ensure the recording, the pulse does not wake up her. Severity, it shows the severity of the hypothyroidism of the patient, mild 80 to 90, moderate between 90 to 100, severe above 100 and per minute. In this patient, systemic examination, respiratory system was normal, CNS almost normal, cardiovascular system was all normal and per abdomen examination is normal. So on the history and the examination, this is the summary of the patient. A 43-year-old female presented to the hospital with painless swelling in front of the neck in midline which has enlarged gradually in last years. with history of suggestive of dysphagia, dyspnea, and hoarseness of voice, and the swelling moves with the deglutition. Our provisional diagnosis is 43-year-old female with large multinodular goiter with pressure symptoms or retrosternal extension posted for the total thyroidectomy. So then we have, what are the investigations we require for this patient? Hemoglobin, all CBC, hemoglobin, LFT, RFT, routine, all hemo investigations we have to do. Thyroid function test is a must. In this patient, thyroid function tests were normal. Chest X-ray in this patient shows some abnormality. Large thyroid mass extending retrosternally to the level of carina on the right side, and the trachea was narrowed and displaced to the left side. On USG, multinodular goiter we seen. ECG was normal, 2D echo was normal. Ideal vocal cords are in normal position, and MRI shows the vascular structures are normal, no tracheal and esophageal invasion. This is the CT scan of neck and thorax where tracheal narrowing is there and huge retrosternal mass is there in the thorax. So how to plan and prepare this patient is a really challenging, but careful planning and preparation you will get the success. Preoperative optimization of thyroid functions and ensuring to normal thyroid hormone level is very important. All the thyroid in all thyroid patients should be e-thyroid before the surgery. It will give the more better results. Comprehensive contingency plan. A general surgeon, cardiothoracic surgeon, ENT surgeon, and anesthesiologist has to be on one page and has to discuss this patient before the surgery, especially these retrosternal goiter patients, regarding the management of difficult airway, acute cardiorespiratory decompensation following the induction of anesthesia. The ENT surgeon has to be standby in the operating room to initiate the rigid bronchoscopy and jet ventilation, and cardiothoracic surgeon and perfusionist have to prepare for the cardiopulmonary bypass as a rescue in the event of failed airway control or severe cardiovascular event. Preoperative preparation, we have to take written high-risk anesthetic informed consent. Preoperative fasting for 6 hours is a must. What anesthesia preparation to be done before induction? We have to keep in mind of the thyroid storm. So 4 units of the cold saline for IV infusion, ice cubes to be kept ready, beta blockers has to be kept ready, and rails to be put in the patient has to be rails tube. 1 unit of cross-matched pack cells also arranged. A difficult airway cart containing LMA, ILMA, iGel, fiber optic bronchoscope, optical ciliate, gum elastic bougie has to be there. 2 working laryngoscope and endotracheal tube 1 to 2 size smaller than the required has to be there in our cart. This is the OT preparation. In this thyroid patient especially, we use the flexometallic tube which prevents the kinking and obstruction. And one more tube we can use neurointegrity monitoring tube, cupped endotracheal tube, and nasal RAE. So our plan in this patient was awake flexible fiber optic intubation because there was huge extension in the retrosternally patient, obstructed symptoms were there. So we have thought we will do the awake intubation. Pre-medication, nebulize the lignocaine to provide the airway anesthesia, nasal drops of otrivine, IV glycopyrrolate. No sedative pre-medication was given. This is very important. Monitoring, all routine monitoring. Here temperature monitoring, ETCO2 monitoring, and peripheral nerve stimulator is very important. And as this patient is very huge thyroid, so we have kept the arterial line and invasive monitoring also, CVP. So anesthesia, it is fiber optic intubation performed under infusion of dexmedetomidine, titrated at the maintenance dose, not you given the loading dose, only maintenance dose. Once the glottic structures were identified, we have given the 2% lignocaine, was sprayed directly into the glottic inlet, and we proceed forwards. Esmolol was administered to obtain the sympathetic response. Tracheal intubation was done with 6 mm cupped flexometallic tube, and the largest inner diameter of the tracheal tube was possible in view of the severe tracheal narrowing, and throat pack was also done to avoid the leak around the tube. Because we have used the small size tube. ET tube was confirmed on ETCO2 graph and air entry equal on both sides. Injection propofol was given, beccurinum, and maintenance with the sevoflurane, air oxygen, and injection dexmedetomidine infusion was started. Here we have to keep intraoperatively this mediastinal mass syndrome can occur, which is a condition caused by the mediastinal mass in patients undergoing anesthesia. It can occur at any stage of anesthesia up to the postoperative period, or even simply by changing of the posture of the patient where acute respiratory and cardiovascular decompensation can occur, direct mechanical compression of the trachea, main bronchi, both the tumor may lead to total airway occlusion, whereas external compression of the nasal vessels, and this will get result in the disaster. And when there is a cannot intubate, cannot oxygen situation, we have think about this potential benefits of veno-venous ECMO in difficult airway management are the possibility to perform surgery in the airway without the need of endotracheal tube for the respiration. ECMO has less bleeding complications compared to cardiopulmonary bypass. Veno-veno ECMO can be used without heparinization for few hours when heparin coated circuit is used. We can use the veno-arterial ECMO also, but it has the limitation. So intraoperatively 1.3 kg tumor was successfully removed by the cervical approach. Trachea was patent, no massive blood loss. After the surgery, direct laryngoscopy was performed and Cormack-Lehane grade also viewed. ATT tube was changed and patient was kept on ventilator for 24 hours. We have done the leak test and the patient was extubated with due all precaution after the 24 hours. Again, we done the direct laryngoscopy, vocal cords are normal. No respiratory compromise was noted after the extubation. Patient had the uneventful recovery. Next few slides for the students. These you have to keep describe the steps of thyroid hormone synthesis. What are the difference between T4 and T3? Then what is the Wolff-Chaikoff effect and Jade-Basedow effect? This is question you will going to ask in exam. You should know iodide decreases T3 and T4 synthesis by inhibiting iodide oxidation and organification. That is the Wolff-Chaikoff effect or thyroid constipation. And iodine to be given for not more than 14 days before the surgery. If given for more days, can produce the recurrence of hyperthyroidism, which is a Jade-Basedow effect, that is a thyroid escape. So how do you prepare the patient when patient is hyperthyroid? All patients be treated with antithyroid drug and beta blocker and make the patient euthyroid. Lugol's iodine you have to use, and advantage is to it reduces the size of the swelling and decreases the vascularity and gland becomes the more firm. How is the patient induced in this patient? IV induction is the first choice. If it is difficult intubation, it is anticipated, then inhalational induction can be preferred. Patient gives the obstruction of his symptom. Then which IV induction is ideal? Thiopentin is an ideal agent, but you can use the propofol also. Any specific type of endotracheal tube used? Already I have discussed. Is there any role of LMA in thyroid surgery? You can maintain the on LMA, but it is very difficult when because the surgery in the neck, movement of the neck, it will give the difficulty. Relative contraindication, tracheal narrowing and deviation. What are the precautions we have to take during the intubation that we have already discussed? Then what is the position used for the thyroidectomy and importance? You all know, patient is positioned
Madam.
with the sandbag. 1 minute.
Madam, please.
So position is very important because they give the head extension and they give the shoulder, and that there is chances of extubation also. So we have to keep in mind when they give the head elevation and they put the shoulder back. So, and you have to keep in mind hypotension and air embolism because they give the head up position. How should the patient is maintained during the surgery? Adequate depth of the anesthesia, oxygen, and patient should be normal ventilated. Continuous monitoring of EtCO2 and temperature is very, very important in these patients. What are the intraoperative complications? Hemorrhage, dysarrhythmia, air embolism, thyroid storm, and delayed recovery from muscle relaxant. What is the thyroid storm and hyperthyroid crisis? You all know, I think, clinical feature we'll discuss. Fever, increased carbon dioxide production, acidosis, hyperventilation, tachycardia, arrhythmia, tremor, coma. These are the symptoms. And how do you recognize? Early exhaustion of the soda lime, canister become hot, hyperpyrexia, increased EtCO2, patient requires more muscle relaxant, and unexplained tachycardia and dysarrhythmia. How do you manage this thyroid crisis? Reduction of the circulating thyroid hormone levels, inhibition of the peripheral effects of this hormone, supportive care, and treatment of the precipitating event. What are the causes of the stridor after the extubation? We have to keep in mind in all the thyroid patients: recurrent laryngeal nerve palsy, tracheomalacia, laryngospasm, laryngeal edema, hypocalcemic tetany, and hematoma. How do you manage? bilateral abdominal palsy, tracheostomy, anesthesia for small thyroid and moderate large thyroid. I think everyone is doing, you all know. We can do this surgery. This is just the finish for PG students. We can give the regional anesthesia and analgesia for thyroid surgery, deep cervical plexus block and superior cervical plexus block. In conclusion, comprehensive preoperative planning, multidisciplinary medical teams were the prerequisite for successful delivery of anesthesia and uneventful recovery of this patient. So let us remain vigilant and prepared for this challenging anesthesia for the retrosternal goiter. These are our references. Thank you. Thank you very much for patient listening. Thank you.
Thank you very much, madam, for a very good presentation. Take home message is, first you have to send these all, you should do all these retrosternal goiter thyroidectomy at institution level or tertiary level, or where there is a
Facility
fiber optic bronchoscopy is
cardiopulmonary.
available.
Fiber
That is the
optic
main-
intubation and cardiopulmonary
Yeah.
bypass facility is available.
Actually,
Especially,
consensus in airway, difficult airway management between the anesthetists is also difficult.
Yeah. So it's better to do in tertiary care center.
Due to
we have a time
we'll
limit.
take question answer later.
Thank you everyone. Thank you.
Thank you.
Thank you so much, ma'am, for a very informative session. I will request Dr. Ruda to escort all the dignitaries to the felicitation point, and Dr. Ganesh Limay sir will felicitate all of them.